Hi, good afternoon to those in the room as well as those over Zoom. My name is Lily, and we're here for the monthly mental health and addiction rounds. And this month we have Jane Kim presenting, who's a research scientist in the Department of Psychiatry, as well as the medical writer working with Dr. Puya Azar at the Complex Pain and Addiction Service at Vancouver General Hospital. And Jane will present today the relationship between pain and opioids and its role in opioid use disorder. So welcome, Jane.
Hi, thank you everyone. Thank you for coming and thank you to those in person who came in this wet weather. I appreciate it. Um, ooh, I can't. Just before I start, I'll talk about like the brief outline on my talk. So first I'll be going over what we've seen so far with the overdose crisis. And then we'll go into the relationship between opioid use and pain. And then we'll move on to what management strategies have been deployed so far. And then finally moving on to some future steps of what we can do to help improve this crisis. So as you all know, we're in the midst of an opioid overdose crisis in Canada that's been taking over more than 50,000 lives since it started in 2016. Natural surveillance began in BC as well as Canada in 2016. And as you see from this figure of observed and projected apparent opioid toxicity deaths, we've really never hit a significant decline since the opioid crisis started. And in 2020, with the beginning of the COVID-19 outbreak, we actually see a significant jump in the number of deaths that has failed to go down since it went up. On the right side of the figure, you see that some simulations expect from what we've seen so far. The overdose prices will inevitably continue to hit an upward slope. The opiate overdose crisis is really hit everywhere throughout Canada, but it's really concentrated in our province of BC. Opiate poisoning is now the leading cause of death for unnatural death in BC, surpassing all of homicides and suicides and motor vehicle accidents all combined. This is especially true for ages 10 to 59. So it's taking away youth and our vulnerable children who don't have the potential to grow up to be like healthy and full functioning adults. Altogether, we've seen in 2024 more than 6 deaths per day happen in the province due to opioid poisoning. And this, unfortunately, is really the lowest annual death toll we've seen in the past 4 years. The opioid overdose crisis is characterized to have come in like three kind of distinct waves of different substances. First, starting in the 2000s with high rises in prescription opioid deaths. Then moving on to 2010 when there was a huge rise in heroin-related deaths come along. And then finally, a few years later, shortly in 2013, when there was a huge rise in fentanyl and synthetic opioid-related deaths. A lot of experts right now believe that we're kind of in the middle of a fourth wave already, mixing polysubstances, but especially stimulants with fentanyl. A lot of people are seeing that either people who use fentanyl purposely seek out stimulants to kind of extend their high, or we see a lot of stimulant deaths from unintended fentanyl being mixed in with their drugs. This is really unfortunate because a recent cohort study showed that people who've used both stimulants and fentanyl, particularly opioids, are at the risk of at least twice more the risk of fatal overdose compared to those who use just stimulants or fentanyl. So the major talk or like topic of my talk today is what is the role of pain in the overdose crisis? Well, starting with the first wave with prescription opioids, is really closely tied to when Purdue Pharma first released their long-acting opioid OxyContin. OxyContin was really like heavily marketed for being less addictive and kind of more acceptable to a wider range of different people with either acute pain or chronic non-cancer pain. And so this led to a really potent long-acting opioid being highly like distributed to a number of people who really didn't need that level of potency in their system. And that kind of led to parallel rises in the opioid prescriptions, as well as parallel rises in addiction and opiate poisonings, which we see in 2012 led to 275 million prescriptions in Canada and the States just combined together. This is really disproportionate to the rest of the other countries, high-income countries that we see, and with United States really pulling the prescriptions forward. In 2013, like after the 275 million prescriptions we see in 2012, we saw 44,000 US overdoses, 37% of which were due to prescription opioids alone. And now in the third/fourth wave, fentanyl is still the major driver of the overdose deaths that we see in Canada and BC. In 2024, we saw an 83% of unregulated drug deaths with fentanyl detected. This means a number of different things. The first saying that people are kind of seeking out fentanyl, so a lot of people are purposely using fentanyl and having it in their systems, versus there's still a lot of adulteration going on. So even people who don't want to seek it out purposely inevitably take it in their systems, and we see such rising numbers. Since 2017, we see that this number really hasn't gone below 80% since it started. Coupled with this is the fact that the amount of fentanyl that people use are really in extreme concentrations now. The BC Coroner Service kind of defined extreme concentrations as being above 50 micrograms a liter. Versus what we consider as a lethal dose of fentanyl to be 2 milligrams in that like tiny bit out of pencil. And so this also means a different number of things. This means that people are rising in tolerances. So the more people are using fentanyl and the more fentanyl is adulterated in the drug supply, people's tolerances go up, and to kind of meet that need, more fentanyl is distributed and adulterated in the drug supply. So how are pain and opioids related? Well, one of the major hypotheses that have been circling around since 1985 is the self-medication hypothesis. The self-medication hypothesis essentially posits that substances are used to cope with pain, both physical and psychological. So this really goes against the popular thought that substances are like sought out for pleasure seeking or to have fun or to be experimental, but it actually says that it's being used as like a relief mechanism to relieve short-term pain. Pain can also be categorized into two kind of broader categories, one being physical pain, which is a sensory response to noxious stimuli or injury, versus psychological pain, which is a lot is associated with traumatic events or oftentimes mental illness. So we kind of wanted to test this hypothesis, which came in 1985 to the 2000s, and see if this is still applicable to now and the substance using population. And we especially wanted to test this in an extremely vulnerable population of the homeless. As you all know, there's a large population of homeless in BC and Canada. In 2021, we actually saw a rapid increase in deaths among people experiencing homelessness in BC. This was a 75% increase from 2020. 74 of these accidental deaths were classified to be from opiate drug toxicity. And then of these, 87% from illicit drug toxicity specifically. So if you see the figure 1 below, it's a little small, but it's essentially comparing what type of hospitalizations people came in people with housing versus people experiencing homelessness. And if you see in the first two columns, you kind of see that fentanyl and heroin is really highly prevalent in people experiencing homelessness, and is the major reason why people are coming to hospitalizations for opiate poisoning. And so this 87% from illicit drug toxicity is really probably, we assume, to be highly from fentanyl and heroin and different types of opioids. So with this, we wanted to test the question, does opioid use predict extreme pain and discomfort in the homeless population in BC? We really wanted to focus on extreme pain regarding the homeless population, because we know that the homeless population go through many different things that separate them from people with housing. So for example, some quick facts about the homeless. In one sample of homeless adults with substance dependence in a downtown East Side SRO, we found that 95% had substance dependence, which is incredibly high considering like a general population. In another recently published systematic review and meta-analysis, they found that 9 in 10 homeless adults were exposed to at least one adverse childhood experience, and over half of them actually had 4 or more. And as you know, considering the kind of situation of the homeless, especially in like winter periods or really hot summer periods, they're really prone to frequent injuries and suffering from concurrent health conditions. So once they hit one injury, the fact that it doesn't goes untreated, coupled with many other like compounding injuries and mental illness, really speaks highly to the fact that homeless are in a different level of pain and discomfort than we would think. And so, which is why we're reiterating the fact that we wanted to test their extreme pain. So for this study, we used two different samples into one study. One of the samples came from the BC Health of the Homeless study, which was a survey of 500 homeless adults that was conducted from May to September of 2009. It was conducted in three different cities in BC, Victoria, Prince George, and Vancouver, with the most amount of participants in Vancouver. So to be eligible for the study, adults needed to be defined as homeless, which we defined in the survey as living in places not meant for human inhabitation. So places like parking lots or cars or tents, as we often see in BC. This study was kind of special because it undertook purposely sampling of women, Aboriginals, and absolute homeless, which is people that live on the streets. We wanted to do this because we really wanted to understand the different types of vulnerability that exists even within the homeless population, and really cater our findings to those who are often like hidden away from other surveys and are more at vulnerable risk. The second sample that we use comes from the Vancouver at Home. Vancouver at Home is a sub-study of a large, like Canadian-wide at-home Cheswa study in 5 Canadian cities conducted from 2009 to 2013. This at-home Cheswa study essentially trialed Housing First. Housing First, in brief, is like an intervention that provided immediate access to housing, subsidized housing, and clinical support to people who are homeless and with mental illness according to like their need of mental illness. So like if they were high need or moderate need, depending on the severity of their mental illness, they were given like different types of clinical support. To be eligible for this study, participants needed to be at least minimum age 19 with mental illness and homeless or precariously housed. So precariously housed in this meeting means that people could have stayed in shelters and they would still fit to be eligible for this study. So for our study, we used the baseline data of 497 people from Vancouver at Home that were collected between 2000 and 2011, just to make sure that before any intervention, we wanted to see what being homelessness was actually like. So to carry out our study, we used two different instruments that thankfully overlapped between the two samples. The first was the Mosley addiction profile. The map collected self-reported data on the frequency and duration of substance use in the past month for participants. And so for each class of substances like alcohol or cannabis, people had to essentially state how much they use and how often they used. And this was all gathered by self-report. The map also collected things like risky substance use, so things like polysubstance use and injection drug use. The other instrument that we used was the EQ5D, which is a standardized quality of life instrument. It measures the quality of life in 5 different sections. As you see there, anxiety, depression, mobility, self-care, pain and discomfort, and usual activities. And for each of these different sections, participants had the option to say they have no problems or some problems or a lot of problems. And so for our study, we obviously focused on the pain and discomfort section, and we saw which people reported extreme levels. So with these kind of data, we first did some binary analyses for comparing people with extreme pain, without extreme pain. And then we used a logistic regression model for each study. So we have 2 models in total. So starting off with the BC Health of the Homeless results, we saw that the mean age of homeless populations collected was 37.9. 62% of them reported being in pain and discomfort, and then 14% of that being in extreme pain and discomfort. When we compared people in extreme pain and discomfort with those without, we saw that the use of illicit prescription opioids were significantly higher in the past month. Compared to the Vancouver home sample, which saw the mean age of 40.8, so just slightly older, 69% of them were pain and discomfort, and then 17% with extreme levels. The use of heroin and illicit methadone here was significantly higher than those without extreme pain and discomfort. as well as injection and daily use of substances. So these results are kind of similar, but we suspect that the slightly higher severity of substance use, including like injection use and daily use in the Vancouver at home sample, really comes from the place of Vancouver and the downtown east side specifically, where a lot of this data was collected, versus BC Health of the Homeless, where they congregated a lot of data from like Prince George and Victoria collectively. So in our regression model, we saw that illicit opioids are associated with extreme pain. So in the BC Health of the Homeless sample, we saw that extreme pain and discomfort was significantly associated with age, as well as illicit prescription opioid use. So people in extreme pain were at least 2 times more likely to use illicit prescription opioids in the past month compared to those without. Same goes figures for the Vancouver at home sample. Those in extreme pain and discomfort were more likely to be older aged and to use illicit methadone, as well as to use drugs daily in the past month. When we put the daily drug use in some follow-up analysis, we actually saw that people tended to use a lot of cannabis in their daily lives. And so we're really interested in seeing how illicit prescription opioid use and cannabis use might couple together to create this kind of self-medication hypothesis. Yes.
On the illicit methadone use.
Like we think that it's like methadone that people have gotten prescribed that are like taken and sold to the streets, and then people buy like that diverted methadone. Yeah.
It's just there because it's easily available and it's easily diverted.
We think so, especially at this like stage in time when it was collected 2009 to 2013. We think that like methadone was kind of more easily obtained and diverted to the streets versus now when there's witness consumption.
Might have been thought of safer.
Yeah.
Hopefully coming from
yeah.
Yeah.
Like people who used to listen methadone versus people who like received who I don't remember. Sorry. This was an old study. I can get back to you. I can get back to you. So our findings altogether for this study really are in support of the self-medication hypothesis. We see that illicit opioids, particularly methadone and prescription, are thought to alleviate extreme pain in homeless populations. We also see significant socio-demographic predictors of age. This is kind of expected, seeing that older age often leads to increased pain sensitivity, as well as people are more prone to like things like falls and injuries. We also see the significance of living in Vancouver. We think that there are, like, it's not just age or living in Vancouver, but we also think that it's kind of synergistically everything contributes to greater opioid use. So people with older adults living in Vancouver, particularly downtown east side, not having access to a shelter, especially for those who are absolutely homeless. And then the service system that we currently have is now and has always been kind of hard to navigate for people with extreme mental health and substance issues. And we kind of think all of these things together really leads to people not having another option but to self-medicate with medications taken from the streets. Another way to look at this is really through something called the iceberg of homelessness, mental health, and addiction, where as the severity of homelessness goes up, so people from like top down, people starting off from lower income and independent housing, eventually move upwards to lose this kind of dependent housing that they have to substandard housing, shelter, and then to the streets. On the left, their physical and psychological pain often goes up with the severity of homelessness that people see. So obviously, when you're living on the streets, you're more prone to facing like traumas from both physical and psychological issues versus if you were to live independently with housing. quite unfortunately, at the right side, we see that available and appropriate treatment for these specific populations also go down. And so there are a lot more general treatments available for people who are in independent housing versus the people at really extreme risk and living in tents and like in the streets often aren't like reached out by systems of care and are like often quite isolated where they are. So we wanted to further explore this question after the rise of fentanyl in 2013 onwards. So fentanyl, as you all know, is a really highly potent synthetic opioids that's estimated to be about like 50 to 100 times more potent than morphine and heroin. The fatal dose of fentanyl that you see on that tiny little coin is the amount that could potentially kill someone that's opioid naive. And what's even more concerning is the rise of carfentanil that we now see. Carfentanil is an analog of fentanyl that's really used in as like an elephant tranquilizer or like in large animals. But we see that since fentanyl has been in the drug system and around our populations with over 80% for the last few years, people are like rising tolerances are having them to resort to even more potent, even like more riskier substances such as carfentanil. So our next question was, what are the factors associated with chronic pain among fentanyl users in Vancouver? We wanted to explore this study through the fentanyl cohort survey. The fentanyl cohort survey is a survey of 250 patients who identifies fentanyl as their primary drug of choice. This survey really came to examine people's fentanyl use, how people use their substances, and their treatment history. And this was really a measure of to identify gaps in the treatment system and how we have failed to kind of adapt to the growing population of fentanyl users. So for this purposes of this survey, we included the first 200 patients that were collected from Vancouver General Hospital. But I think in total, there's about 250 so far. The survey really came up because not even just because of the proliferation of fentanyl that we see, but because we're seeing increasing preferences for fentanyl come up in the population of drug users. So people with opioid users have kind of quickly evolved from fentanyl being like a common adulterant in heroin and other opioids to really purposely seeking out fentanyl for that potency and high. So in the fentanyl cohort survey, we also asked this question, considering how lethal and potent fentanyl is, why do you take fentanyl and why is it your drug of choice? And so we asked this question and we got some few qualitative answers that were kind of broadly structured into 5 different categories. The first being it helps with pain, as we kind of expect. The second being the best bang for the buck, so being a cost-effective option because it's synthetically produced. A lot of it is kind of easily obtainable in Vancouver for lower prices. It takes away all my negative things at once. So we see another tie to kind of psychological pain. So fentanyl being used as a measure of seeking and alleviating psychological pain. There are some people that enjoy the high of and the euphoric effects of fentanyl itself. And then the last one, plan B, if you can't get what you need, also speaks to the separation of people that we see from the care system and the lack of kind of prescribed treatment strategies that they can receive. And so people in need of pain treatment go towards like unprescribed fentanyl and go to seeking on the streets. Mm-hmm.
When was the survey taken during the course of their development of fentanyl? Is it at the start, or is it when it's well established and they've experienced a few relapse episodes?
A lot of our samples were kind of in the middle. They were a few years into using fentanyl, so a lot of people started, I think, about 3 or 5 years before we collected the survey. Yeah, no worries. So for our study, we conducted this in 3 different questions that were involved in the survey. First being, have you experienced chronic pain in the last 6 months? For the purposes of our study, we define chronic pain as lasting for over 3 months. The second question is, what would your average pain level on a typical day? And then how does your opioid use relate to your chronic pain? So this was a kind of open-ended questionnaire that people had 4 categories that they could potentially pick out if they wanted. The first being self-medication, second, losing access to prescription opioids that they previously had, but they lost. Prescription opioids not being strong enough, so even when they were prescribed something, maybe it didn't fit their needs. And then lastly, having no access to prescription opioids, so not having like a doctor or a primary physician being able to prescribe them opioids. So similar to the first study, we conducted bivariate and regression analysis with the data collected from these questions. So for our results, this is from the first 200 participants of the survey. 73% reported suffering from chronic pain in the past 6 months. So this means that the 73% were suffering from ongoing pain in the last 3 months continuously. These chronic pain users said that their mean level of pain on a typical day was as high as 7.6, so almost 8 out of 10. And then 66% of them also said that they use street opioids specifically as a method to self-medicate. In our bivariate analysis, we found that more individuals with chronic pain than without chronic pain were more likely to be thinking of reducing or stopping fentanyl use. So this is kind of an interesting finding, considering that because these people are facing such extreme levels of pain, we might expect that they're seeking out fentanyl purposely to kind of alleviate their pain. But coincidentally, they actually want to reduce or stop fentanyl, but are inevitably using fentanyl day to day. So in our regression analysis, we sought to find the factors that were independently associated with chronic pain, the existence of chronic pain or without. So we saw that age as well as the co-use of opioids with cannabis were both significantly and positively associated with chronic pain. So much like in the other sample, like older age was heavily associated with people having chronic pain, as well as co-use of opioids with cannabis, which is similar to what we saw in the Vancouver home study, where people were daily using cannabis as a way to treat their pain. We wanted to follow this up with another regression analysis on the levels of pain that they experienced on a daily basis with chronic pain. And so we found that the higher the level of pain that they experienced on a daily basis were associated with age and self-medication. So the more people were in pain on a daily basis, the more likely to be they were older, as well as to self-medicate. So this study kind of highlights that chronic pain drives fentanyl use in the Vancouver populations. Most people with chronic pain were found to self-medicate with fentanyl, but the finding that people wanted to reduce or stop their fentanyl use, but were still part of the survey and identified fentanyl as their primary drug of choice is kind of ironical. And we see that maybe fentanyl is an unwanted consequence of the current market. So maybe without people really like seeking out fentanyl purposely and liking their high and euphoric effects, maybe it's the fact that fentanyl has really been driven in and kind of almost pushed into people's faces because of its cost effectiveness and its like adulteration in the market. We also see, as with the first study, we see a vulnerability of older adults that are maybe considered less prioritized as they should be in the current opioid crisis. We see a lot of older adults going towards self-medication and fentanyl use, and this like highlights that maybe more treatment strategies should focus on helping older adults cope with their pain so that they don't have to continue the daily use of fentanyl. So with these two studies, we see that a lot of relationship with pain and opioid use, particularly fentanyl, in the two studies that we conducted in BC and Vancouver. So we wanted to consolidate this with the broader literature and see what is the association between fentanyl use and pain in like the global literature. So outside of just Vancouver and Canada, a lot of substance use is also happening in like the UK and Sweden, Iceland, and so forth. We wanted to see what our findings matched to the findings that others had internationally. So we did this through a systematic review. Our main goal was to identify whether the proliferation of fentanyl may be correlated to untreated pain outside of Vancouver. So is this a specifically Vancouver and BC, Canada thing, or is it also happening outside of Canada? We wanted to specifically ask how fentanyl is being used, so how fentanyl is being diverted and misused, what kind of routes of administration people are taking. And we also wanted to ask why, like, why are people purposely seeking out fentanyl? We see in Vancouver, it's maybe highly related to cost effectiveness and pain. Why is it being used in other countries? So we did this through 4 database academic searches with the wide concepts of like pain and misuse and opioid use. We included all studies that described fentanyl and misuse and pain, and excluded all other studies that described other opioids or described fentanyl being used like in a clinical setting instead of outside. So we started with 4,261 studies, and after abstract and title screening and full text screening, we actually resulted in a final total of 22 studies. So this search was conducted in 2024. So we're kind of expecting that if we were to redo the search now, we'll end up with more studies. But I think the finding that we started with a first total of 4,000 and we trickled down all the way to 22 kind of point to the fact that people with fentanyl use still aren't well like researched and are available in the literature. We still don't know too much about how they operate and how and why they use their fentanyl. But we still wanted to consolidate what we found into our findings. So we saw various uses of fentanyl and like places worldwide, locations being Canada, US, primarily the States, the UK, Greece, and Australia. Once again, this study was conducted in the early years of 2024, so we're expecting that a lot more widespread availability is probably seen by now. A lot of the sources of fentanyl that we see were from diverted materials or the misuse of prescriptions. So people were prescribed medical fentanyl and either chose to misuse them in ways that weren't as they were directed to use, or people sought them out on the streets, so they were purposely seeking diverted fentanyl instead of fentanyl that may have been produced organically and sold. A lot of the routes that we saw were intravenous, transdermal, nasal, and oral. We saw a lot of different routes that people were taking fentanyl, but primarily we saw a lot of intravenous use and transdermal use. So something that interesting we saw about transdermal patches specifically was in the first scenario, people were really non-compliant with the amount or frequency of transdermal patches that they were given. So they would either be changing them too frequently or they were putting on more patches than they were prescribed for. This is kind of a common case. The second more interesting case is a lot of people were actually injecting the extracted fentanyl from the patches intravenously. So in a transdermal patch, there's 4 different types. But one of the most important is the rate controlling membrane. So as a transdermal patch, the kind of rate limiting step is when a patch gets onto your skin and undergoes passive diffusion into the top epidermis. And so people were choosing to pass this rate limiting step by taking the drug reservoir directly with a needle and then injecting it into themselves directly. And so a lot of the cases, if not all the cases we saw of people injecting extracted fentanyl were fatal cases. So people were found on the scene with used needles and syringes and fentanyl patches. So this actually speaks to a lot of, because fentanyl patches are more easily accessible than intravenous fentanyl or fentanyl that's used within hospital settings. This actually speaks to a lot of dangers of needing to communicate out to people who use drugs of the dangers of doing this. Considering the fact that we saw a lot of fatal cases, see that because people are injecting with a bolus dose, they're giving themselves a lot of fentanyl at a extremely quickly rate. So people are high risk of fatal overdose. And this is something that I personally haven't seen reported a lot in the literature, and it deserves a lot more attention and education about. In the systematic review, we also found 2 kind of major reasons for using unprescribed fentanyl. The first is pain, but it's also in the bigger umbrella of people experiencing poor experiences with the healthcare system. So a lot of people were written down by stigma. So people who use fentanyl are at really extremely high opioid tolerance. And so a lot of the prescriptions and treatment systems that are being given within the hospital may actually not suit their needs. according to like how much they may have been using like on the streets. And so people felt a lot of stigma for asking for more, or like they felt in general people who use drugs are poorly like treated in the healthcare system in general. And so this led to a lot of people leaving AMAs and not returning to the hospital when they could have really like used that help. So instead of returning back to a hospital or engaging with the healthcare system as a whole, they would turn back and go back to using unprescribed fentanyl. A lot of the high tolerances that we see with fentanyl use are aligned with inconsistent protocols and rapid dose reductions that we currently see. So starting with the first wave, the guidelines that are set in place today for opioid use disorder are really like majority from the heroin era, so like starting from the second wave, and they haven't been too well adjusted to the people who use fentanyl that we really heavily see right now. And so the guidelines report a lot of smaller doses than people would be like used to. And so because of this ongoing like pain, people might be thrown into precipitated withdrawal if not given too carefully. And so because of all these things, a lot of people felt that their healthcare system did not align with what they needed and what they wanted. And so they would leave and elect to use unprescribed fentanyl. Another thing is high costs, including, so like in countries outside of Canada, obviously prescription medications come at a cost. And so people who are like unable to pay those prescriptions also went for the cheaper options on the street. I was going to give an example of a structural like example of how like the healthcare system may be falling behind. This is a link of like how long you have to wait for at an emergency room. Not sure how many of people have used it, but the last time I checked at my home, last night, the hours you had to wait for an emergency room physician to come see you was not 6 hours and 45 minutes. So people have to like go to the emergency room, report what their pain is, their name, and etc. And then they have to wait in the waiting room for at least 7 hours, 4 to 7 hours until someone comes to see them. And so people who are in extreme pain and discomfort may not obviously be willing to wait that long for a person to see them, and then they would leave. The second major reason for why people chose to use unprescribed fentanyl were, like we found with the fentanyl cohort survey, it's the advantages that fentanyl brought as its own unique pharmacology. So fentanyl has a really rapid onset compared to other opioids. And so people who are in extreme pain, much like the emergency room, are not willing to wait hours until their opioids kind of kick in. And so they choose to use fentanyl, even if they have to extract it from a fentanyl patch and inject it into themselves directly. People don't want to wait for care to come to them. Another advantage, of course, is the higher availability and lower cost of fentanyl. Earlier this month, I think BC just seized like a drug super lab in rural BC that was published, that was building a lot of fentanyl and distributing it. And so because fentanyl is a synthetic opioid and a lot of it is being maintained like now, like here in Canada, without having to bring in like precursors and other ingredients from other countries, the fentanyl proliferation has been made really easy and for people to get. And so because it's synthetic, people don't need to pay a lot to get a lot of fentanyl. And so this is again another major advantage that people see. So the next kind of question is, we see a lot of pain and we see a lot of opioid use in correspondence. What is being done and what are the kind of main pain management strategies that are existing right now to deal with this kind of thing? So right now we're being in the middle of conducting a systematic review of pain management strategies for patients receiving very specifically extended release buprenorphine or Sublocade in Canada. But throughout this systematic review, we kind of found broadly for patients receiving any kind of OAT, there really is an overall lack of rigorous evidence of pain management. So a lot of the pain management strategies that do exist are focused on very specific types of pain, so acute pain or critical care, or for post-operative settings. And they aren't focused on like the chronic pain and severe pain that we see in our populations. And tied with this is a lack of evidence-based guidelines. So a lot of experts kind of point to the same thing. If people are on OAT, they should continue OAT and make sure that people don't like relapse or go into withdrawal. And if people are in like acute pain, we should use non-opioids, escalated by like opioid use if their pain is like more severe, and then followed by like regional anesthesia and like even stronger opioids if they're in severe pain. So this kind of basic understanding is the same for all types of pain. But I think what we found in our review was that up to like individual patients, it was really up to the prescriber doing what they thought like individually would work for the patient. So instead of like broad general guidelines, actually teaching prescribers the right way to do things in complex cases, providers were mainly left on their own to kind of figure it out and try different opioids and non-opioids, hoping to reduce patients' pain before they left AMA. So why is this the case? Why are there a lack of pain management guidelines for people with OUD? This really comes from two major topics. First being an over-reliance on opioids. So we see that people are really in urgent need of pain management. We see that opioids are actually really effective of alleviating pain. And we see limited therapeutic options for like chronic pain and severe pain. So all of this combined together have led to an over-reliance on opioids that have started the first wave of the opioid crisis and is kind of continuing to this day. But a lot of people don't know what else to use besides opioids when it comes to like severe and chronic pain. This is kind of coupled with the risk of long-term opioid use, which obviously leads to things like dependence and addiction and things like precipitated withdrawal in patients. And prescribers themselves are also naturally kind of fearful of prescribing too much opioids and inadvertently like either promoting people's like drug-seeking behavior by accident, or in cases like the United States, even facing like legal repercussions for overuse of prescription opioids. And so all of these kind of combined together have led to there still being a controversy of pain management and being an overall like lack of studies focused on how to improve people's pain for people who are using opioids and are in need of opioid use disorder treatment. So we, from consolidating from our findings and with the broader like literature, what are future steps to improve the system of care for people with pain and OUD? These are really broad suggestions from experts that I've collected that I'm presenting right now. First of them is integrated care. A very recent systematic review by Dr. Vigo at UBC found that only 6.9% of people worldwide receive effective treatment for mental health or substance use disorder. This is really tragic considering the severity and the scale of the problem that we see. A lot of the people with mental health or substance use issues can be kind of categorized into 4 different quadrants. A lot of the patients that we deal with either at CPAS or like in Vancouver downtown in general are people at quadrant B, so people with both severe mental illness and severe substance misuse. So for this high-risk population, let alone the general like bigger population, there is a severe lack of treatment for mental health and substance use. And what we're really seeing is the fact that these conditions really come coupled together and they lead to each other. So synergistically, there needs to be a treatment pathway that really cares for both these symptoms so that people don't lead to like self-medication or seeking fentanyl on the streets. If people are taking care of their psychological and physical pain, maybe we can stop or limit the amount that they'll choose to self-medicate with like unprescribed fentanyl and other like illicit opioids on the street. The second kind of bigger solution is investing in digital solutions. And so because considering the scope of the over-the crisis that we see right now, it's really hard to actually get these people in pain to come to the healthcare system, wait 7 hours in the ED, and then give them treatment. So to really reach a wider range of people in a short period of time, a lot of experts believe that investing into digital solutions and online solutions may help people like be in touch with the healthcare provider, even not physically, but maybe it's one way that we can reach out the sources that we do have to the greater population. So in brief, I just wanted to really quickly highlight 2 types of digital solutions that we have that are increasing like evidence of efficacy that we see. The first is like individualized care. This comes from Dr. Michael Krause's RAMP platform, risk assessment and management platform. And this is a really individualized digital solution because each user is allowed like resources that are individualized to their like sort of need. So people go through like a risk assessment of how likely they are at risk of the next kind of overdose and are given tailored content to kind of reduce that risk. And so this is really special because it's a person-to-person kind of support. So if I were to have trouble with opioid use, which I do not, but if I do, I could log into RAMP and see what kind of resources were available for me to use. And even if physical resources weren't available for me to use immediately, some online psychosocial support is at the minimum. And this also highlights that people who are perhaps at higher risk of opioid overdose can be like escalated so that they can see care faster than just endlessly waiting until their time comes. The second kind of broad category of digital solutions is like a universal school-based solution. So this comes from the Our Futures Institute in Australia. So this is like a drug and alcohol-based like education e-health system, education like platform that's being delivered throughout a lot of schools in Australia. So starting from grade 8, people are given access to this online platform where they can learn about drug and alcohol use and the risks associated with those things in like a comic-based format so it's a lot easily accessible to kids. So this is a lot focused on early intervention and prevention. So a lot of students hopefully before they start using drugs or alcohol are caught like in time and are taught about the risks so that they know what they're getting into. And it's a way of prevention that's really helpful because it partnerships with a lot of like schools already. And so it's being built into the school system where kids like go and like see their peers every day really helps kids like hopefully understand all the risks that substance use carries. And the last lot needs is translational research. And so in earlier this month, the FDA just approved the first type of new non-opioid pain medication in 25 years. So in the past 25 years, we really never had a new type of medication come out for treating people's pain. This is really due to what a lot of science is calling the valley of death, or like the translational gap between basic science and clinical science. A lot of people in academia, as well as like in scientific labs, have a lot of potential like ideas for what new treatments could be. But then they're kind of stuck in this large gap between when they actually hit like industry and clinical science and when they can actually help people in need because of the large amount of hurdles that they have to go through to make sure that this is really efficacious and safe. A lot of these things are obviously needed, but a lot of the fact comes from the fact that a lot of these things take time. So obviously things like preclinical studies, healthy subject studies, and all the clinical studies following and post-marketing studies, they're all needed to make sure that all the new types of treatments are safe and efficacious. But the translational gap really comes from the fact that all of these take such a long amount of time. Conducting one kind of study takes years. And so going through all the hurdles from preclinical all the way to clinical science loses a lot of potential new treatments in this translational gap that we see. So something that a lot of experts also propose is that animal research and human research should be conducted in parallel so that a lot of the potential mechanisms that we see in animal research could be like more easily and fastly translated into human research. So instead of conducting the two different types of research kind of separately, we should really aim to focus on combining it together and to really go past the translational gap as fast as we can. So hopefully the next type of pain medication doesn't come in the next 25 years, but it comes in a lesser amount of time, especially in this time of dire need when people are in pain. And because they're at a lack of anything else that they can use, they choose self-medication with fentanyl. That was the end of my presentation. Thank you so much for everyone that listened to me both online and offline. I just want to say a quick thank you to my mentors and all the collaborators that have helped me throughout this process. A lot of the studies all of the studies could not have been done without like mentorship I gained from Dr. Michael Kraus and from the Addictions and Concurrent Disorders Research Group and their team, including Dr. Fiona Choi and Carrie Martha, as well as Dr. Priya Jar from the Complex Pain and Addiction Service where I'm working now. Dr. Marie Thiessen is the person that has developed the Our Futures Institute that we've seen, as well as Diana and Kuvia, who are research assistants that really helped push along the studies that I've talked about today. Thank you.
So I'm wondering what alternatives there are. Thought the release of
I think in places outside of Canada and the States where like there's less kind of over reliance on opioids and like the less of the prescription opioid crisis that we see, opioids are like the kind of first mainstay of treatment as far as I know. But places like Japan and kind of Asia are interesting because they also rely a lot on like traditional medications, so things that are like gathered from plants and other kind of earthly sources that people like seem to find a lot of comfort in. There's also a lot of things that we don't see in the Western healthcare system, like acupuncture and more cultural treatments that are being used in like Japan and other countries. It will be really helpful to see if those kind of like more interesting, more like non-traditional kind of healthcare efforts like are translated in Canada and the States where opioids are the mainstay of treatment. Yeah. Yeah.
Time they talk because we put a big grant application item where we're trying to emphasize the role of hypersensitivity to pain during withdrawal from opioids being, this is Coop's idea that this is the driving factor that maintains the dependence on these drugs because it's relieving,
Mm-hmm.
you know, a chronic state. And one of the referees queried whether or not that was actually a real condition. Is there really a relationship? All you need on these sorts of committees is one person. Basic but more to the point about having an accurate picture of what's happening with opioid use disorder. I don't hear any consideration really about the fact that opioids are, even though they're the best painkillers we have, are completely imperfect in terms of the pharmacodynamics. Because while they work really well initially, they're subject to tremendous tolerance effects. And then also there's this preclinical literature, well recognized hypersensitivity to pain that results even when you're taking regular opioid use to manage pain. So there's this complex interaction between the drug and it altering the physiology in such a way that it maintains the dependence, like it heightens the sensitivity to pain. And the only relief you get is from increasing the amount of opioids. You know, and it's said rightly about relative absence of really effective pain management. It's not opioid.
Yeah.
And then in our animal studies, we're really interested in phenomenon where the sensitivity to pain becomes even more intense during the withdrawal phase.
Yeah.
It's like a step function. And so if you've got somebody, you know, and again, it's really hard to do this kind of work, but if you take under consideration the patterns of use, how many times do individuals go into withdrawal or experience maybe a temporary period of withdrawal, maybe only a few hours long. But nevertheless, they're experiencing withdrawal with heightened sensitivity to pain.
Yeah.
That passes, they go back on it.
Yeah.
And you've got this whole pattern of this discontinuous. And so where am I going with this? I'm trying to get a handle on how you get objective measures of what's happening really in pain sensitivity. Doing your best, obviously.
Yeah.
Would it be feasible to try to do studies with a smaller group, just to try to measure pain objectively over time, and get a more complete understanding of? I mean, first of all, you obviously believe that the relationship between the experience of pain and opioid use is a real relationship. So then the next thing is to really be able to describe that, see whether it's a primary determinant or it's a sort of a secondary consequence.
Yeah. Yeah, I agree. A lot of the lack of data that we see comes from the fact that pain is really like a subjective measure. So what I consider to be a level of 8, Fiona might consider to be a level of 2. And so this kind of discrepancy that we see is like doesn't help us really objectively understand how pain and like what severity of pain really leads to opioid use. And a lot of these pain is also like psychological. So it's not physical pain that people are experiencing, but like people are like traumatized and wanting to seek like their emotional state with opioids. This is even harder to like measure. How do we measure people's like trauma levels or past psychological distress levels and associate them with how like they use opioids? But regarding just like the physical pain alone, it would be really interesting to collect like objective measures of pain and see like validate them in like a large like different samples. Yeah.
Development of all these digital sensors, except one thing floating around my mind is totally impractical for it. Nevertheless, if you could have some passive way of assessing 2 or 3 things that are good markers of pain, and you just track this, you know, in conjunction with the everyday life of someone who's dependent on it.
Yeah.
I think you get amazing. Thank you for doing the work. Really.
Thank you.
John has it.
Because I'm under someone who's got a 2 on a level. Seeking and need to.
Yeah.
But an objective method almost like demonstrates that freedom. So I agree with that. Is it to justify whether someone should be receiving patient or not when you have an objective measure? Is it to verify that what they're saying is painful is in fact painful? And what would be the real goal for having this objective? You can say, yes, you should have that, or is it to show that?
It's a very good point. Because obviously, ultimately, pain is a psychological process. And I guess the fact that, but you can measure it objectively by maybe markers, you know, in terms of heart rate and other things that are subliminal to the person. They may be actually experiencing some form of distress and pain without overreacting to it psychologically. It's not in the consciousness all the time, right? But it's the driving factor that is causing them to seek the drug. Even though, I mean, that's the other thing. You tell people about the dangers and psychologically they just ignore that and risk their life in order to maintain their dependence. So it's just a matter of trying to get a different angle, and one that is less variable and maybe more consistent across individuals. So this all of this makes for more reliable data and maybe gives you a more objective, like, you know, the guy saying, well, we don't believe that there is hypersensitivity to pain. or, even withdrawal-induced hypersensitivity. And we get the evidence that convinces them. Yeah, but don't keep prodding me with this. Very important.
In my head, it's kind of like the cows and sows scale. Like you need both subjective and objective measures to see like when to start kind of treatment and what kind of treatment is available for like the severity of people, the pain. You see, if there was like an objective measure of seeing how painful something was in a person, that was kind of reminiscent of like how severe the withdrawal is in a person. And if they had both like clinical and like subjective scales, I think it would lead to a lot of interesting findings, but I understand that's really hard to come by.
That's the sort of to recognize the fact that most of us are easily misled by our way we think about things, psychological.
Maybe just maybe there's psychological aspects of pain that you can't be operationalizing with objective measures, but then there are some aspects of pain that you can, and like maybe it helps, guiding treatment decisions and also avoiding like relying on patients being accurate historians. I was reading some papers, even like training to recognize and describe their own pain makes them more accurate reporters of their own pain.
Like psychophysics.
But yeah, it's not replacing subjectivity, having both.
Okay, I'll make it. So when you were quite properly putting together the relationship between mental health issues and substance abuse and pain, well, I think there might be some value in recognizing that the pain condition is a third arm of all this. It's not just something that actually is. And it just speaks to the fact that in medicine, we don't really understand the nature of pain and its chronic treatment. I think we don't understand addiction and we don't understand mental health. We don't even understand pain. So now you've got a situation where pain is a prominent feature. It's a tripart model of it. Dual model. And how much is that pain dimension driving the other two elements? I think in the addiction situation, once you move into the chronic condition, my bias is that it's probably a major determinant. And then, of course, as you're experiencing the dependence on drugs and the continuous chronic experience of pain, how that it impacts on your like some equivalents of say post-traumatic stress disorder. If you're in those two dimensions imposing on you, then that confounds your situation. And so I see the pain dimension, and I never used to think this way. You know, I used to see it as something completely different. People would argue that, you know, to really understand addiction, you have to look at pain and the dependence on drugs together. I was thinking solely in terms of driving of the hedonic emotional side of the equation. That's way too simple.
So it's always good to like mine all the data and stuff like that. But I imagine like setting up a new survey to catch like changing patterns in more real time is complicated because, you know, setting up these studies pretty long amount of time.
Yeah.
How long would a survey like this take time to conceive and implement and downtown?
Yeah, for the fentanyl cohort survey, I think it took about a year, if not 2 years. The idea was started really early on, but the actual implementation took a while, especially working with like ethics boards about like, because these patients are so vulnerable, we don't want to put them at any risk of trauma, even if it's just like a survey and not like a clinical study. Um, and the fentanyl cohort survey was really successful. We had 200 participants actually recruited pretty fast because it was conducted at an inpatient like service at a hospital. So to actually gather the perspectives and opinions of people who are in drenched in downtown East Side and in these like extreme conditions would be really hard, and I think would take a lot of manpower and like effort. Thank you. Thank you.